Speaker is Giuseppe Catanuto. Giuseppe is one of the surgeons from Sicily in Italy, and Giuseppe runs lots of activities and lots of educational stuff. He's going to talk to us about placement, scar placement and breast conserving surgery. Giuseppe?
Thank you very much, Yazan. Good evening, everybody. I just need a couple of seconds to set up my screen. Okay. Can you see my presentation now? Okay. So thank you very much again. I've tried to keep my presentation very simple. I'm going to.
I cannot see the share screen. Can everybody else see it? No. So can you share screen again, please, Giuseppe?
Yes.
I think, PJ, you stopped sharing screening, isn't it?
Yes, I have.
Okay, so
okay, let me try again.
The green button at the bottom says share screen.
Yes, sure.
Because we tried that.
Is that okay?
That's great, Giuseppe.
Okay, thank you very much. Okay. So, thank you once again, and sorry, so I'm going to talk about scar placement in breast conserving surgery. The previous talks were very interesting because I've seen a couple of historical backgrounds related to breast conserving surgery and central coronectomies and mastectomies as well. Okay. So I want to start with the historical background as well regarding breast conserving surgery. And I want to go back to the origin of breast conserving surgery, showing you this picture that was published in 1977. This is the first report of the Milano 1 Veronese trial, comparing breast conserving surgery to mastectomy. And you can see how large was the incision anticipated by Professor Veronese to remove breast cancer, either in the upper of the quadrant. You see how big, with extensive removal of skin and with removal of gland down to the fascia. And then on the other side, if they, this is a very nice, naive picture that is showing that if you had to treat a lump in the lower pole of the breast, such a big incision that was also including, let's say, the upper abdomen of the breast. So at that time, they had no idea how to manage breast conserving surgery, how to place skin incisions to avoid deformities and to prevent bad cosmetic results. There were, let's say, two worlds: the world of the hell of mastectomy, and then on the other side, the heaven of breast conserving surgery. Whatever you preserved that had an epilareolar complex and some glandular tissue, that was a good cosmetic result. More or less the same was done by Bernard Fisher in the BO6 trial. We may say here that they did not include skin and they suggest a short, curvilinear or transverse incision. But even in this case, there is no surgical planning in order to avoid bad cosmetic results. So by the end of the decade, at the beginning of the 90s, it was clear that breast conserving surgery that was not really planned in order to provide good final results certainly was giving bad cosmetic results in over 2/3 of the patients just before giving them radiotherapy. And this is a very interesting report that was published in 1990 by Mattery as well. So in the following decade, after 1990, post-breast conserving therapy defects were classified and studied. And this is a very interesting classification. This is probably one of the last classification on defects after breast conserving surgery, which I personally use, and I like it very much because it's also explaining the way you can use to treat defects, residual defect after breast conserving surgery. This is the F2C classification. You can see the level 1, when you just have a small depressed scar that you can correct with a Z-plasty or maybe nowadays using fat grafting. from level 1 up to level 5, very complex deformities with, after breast conserving surgery, followed by radiotherapy. And in this case, you possibly need a mastectomy to rebuild a reasonable breast mound. And so it is a huge damage that was performed on this patient. In the middle, you can see some minor deformities that can be corrected either with local flats or with LD flats, such as the grade 4, or minor deformities that may require a contralateral adjustment, level 3, and level 2, a normal breast, a good shape of the breast that may require contralateral adjustment to reach the symmetry. Okay. I think that at the beginning of the year 2000, after the 90s, let's say, we witnessed some studies, especially studies from the Germans, especially from Werner Odrich, who is one of the guests of our international conference that we held every 2 years in Milan, that were studying deterioration of cosmetic results, were mainly based as a rationale on deterioration of cosmetic results, were really based on how to prevent cosmetic results. So this is the first report from Werner Odrich that is talking about tumor-specific immediate reconstruction in breast cancer patients. And you can see that he's very concentrated on cosmetic results and is proposing an adaptation of cosmetic surgery to breast cancer surgery as far as volume displacement techniques are concerned. Whereas on the other side, sometimes when you need to remove a very large area of the breast, they can also propose tissue replacement using a latissimus dorsi. So very complex surgery, very extended surgery. I want to remember you that at that time, due to the Milan trial, there was also some reasonable ideas regarding the extension of removal in order to prevent local recurrences. The larger the removal in the Milan 2 trial, the safer the technique, the lower the local recurrence rate. Nowadays, we know that this is not really true because we can control local recurrence either using systemic therapy or radiotherapy that is performed in a much more efficient way. So clearly, this approach that was the standard oncoplastic approach, the original oncoplastic approach that was proposed by Krishna Kloff, by Werner Odrich at the very beginning of the year 2000, had several limitations. Well, first of all, sometimes you need, very often, you may need bilateral procedures such as operation on the contralateral LT side in order to prevent asymmetries. And the cost effectiveness of this approach is not really known. And nowadays we know that we have beneficial effects of radiation therapy, either on survival, but also on local control of disease. And again, even systemic therapy is providing good control of local disease. And there is also another concept that we have to bear in mind. When you perform such a displacement, very complex displacement, and you use glandular flaps to rearrange the breast, sometimes you miss the tumor bed, and therefore it's not possible to perform proper radiation in the tumor bed. And we know that proper radiation in the tumor bed is mandatory if you want to have perfect local control of the breast. The conservative concept at that time, at the beginning of year 2000, was also extended by our team, Maurizio Nava, Nicola, Rocco, and the other guys in Milan, was extended also to mastectomies. And you can see in this nice paper that was published in 2009 and named this technique conservative mastectomies, which is quite an oxymoron. You can see that even in this case, skin incisions are designed in order to get as much as possible cosmetic results, with very tiny adjustment even on the contralateral breast, as you can see in this lady here, who had a contralateral small augmentation in order to get a perfect symmetry after a mastectomy. But skin incision after mastectomy and reconstruction were also studied in order to perform a DTI breast reconstruction with symmetrical scarring with a contralateral breast, as in this case. And we published in 2004 the skin-reducing mastectomy that was very promising. So everything was designed to avoid bad results, to optimize cosmetic results, especially on the side of cosmetic results. So I think that nowadays we are running a third wave of breast conserving surgery. The third wave is mainly based on information based on what I call oncoplastic imaging. We get a lot of information from oncoplastic imaging. We have information that means digital mammography, MRIs, tomosynthesis. You can have information regarding vascularity of the breast. You can have information regarding the thickness of the flaps when you want to perform a mastectomy and reconstruction, but also for breast conserving surgery, you can we know now that there is a correlation between the density of the breast and the risk of complications after therapeutic mammoplasties or breast conserving surgery. So this at the beginning. Then we have a multidimensional planning because we can use also primary systemic treatment to adjust surgical treatment. And there is a widespread use of primary systemic treatment, which is not only neoadjuvant chemotherapy, but is also endocrine primary therapy that can be used to reduce the size of the lump and to rearrange and possibly to shift the patient from a mastectomy, especially elderly patient, from a mastectomy to breast conserving surgery. Again, we know now the beneficial effects, and PG discussed this, the beneficial effects of radiation therapy also on survival. And so sometimes when a patient is maybe is requiring a mastectomy rather than breast conserving surgery, we can tell her that possibly there could be an advantage. We are not sure about this because the evidence is rather frail, but there could be an advantage in performing breast conserving surgery and radiation therapy also on overall survival. Also, nowadays we have very refined techniques for tissue replacement that can spare large myocutaneous flaps such as a latissimus dorsi flap for repair of breast conserving surgery, and we got perforated flaps, which are quite efficient, quite simple surgery that can be used to shift patient from a mastectomy to breast conserving surgery, providing rewarding cosmetic results. Finally, and this is one of the hits, let's say, of Greta, techniques should be designed to bear in mind patient expectation and cost effectiveness. We are trying to extend as much as possible patients' participation to the shared decision process. And I think that this is a very nice slide that we are trying to study and develop, in which we are putting in the middle of the decision-making process patients in order to get a shared decision and to get their satisfaction as much as possible. Anyway, when we plan breast conserving surgery, nowadays we use this complex pathway that is including cancer-related drivers. So we have to perform a local staging of the disease to see how the disease is dislocated inside the breast. Then, of course, we need some information regarding genetic testing, because if you got a patient that has a high risk, has a family history of breast cancer with high risk and possibly BRCA1 or 2 mutation, well, that patient could be shifted from breast conserving surgery to a mastectomy. You have to change your decision. You have to move in a way from breast conserving surgery to a more complex procedure. But then you need information also regarding molecular subtypes, because nowadays we treat nearly all patients that can be candidate to primary systemic treatment with HER2 positive disease or triple negative breast cancer. And then you have to make the plan for the skin incision after assessing the results of primary systemic or primary neoadjuvant Herceptin or chemotherapy, depending on the subtypes. And then, of course, you have to investigate the position of the cancer. If the cancer is in the central quadrant, as we have already seen, or in the other areas of the breast. So then we can move to breast and body features. So bear in mind that you have to look at the patient as a whole, not only at the breast, because you can need in the next future to perform a mastectomy, and you need to plan the incision for breast conserving surgery in order to perform a safe mastectomy and reconstruction later on if you get positive margins at the first or the second operation. And so you need to understand what kind of breast reconstruction you may perform when you need to shift from breast conservation to mastectomy. You may need an abdominal flap, and so you have to check for flap donor sites, and you may need fat grafting to correct the results of the bad breast reconstruction or bad breast conserving surgery. So again, try to look at the patient as a whole, not only in terms of communication, assessment of patient values, but also as a whole, as a human body. So distribution of fat, and of course, shape of the breast. If she's got a very large breast, you can safely perform breast conserving surgery, even if she has got quite an extended disease. Whereas if she's got a small lump in a small breast, that would be very difficult, especially if the lump is in the upper inner quadrant, for instance, or in the lower quadrants. And in that case, you need to explore the possibility to shift from breast conserving surgery to a mastectomy in order to perform surgery with reasonable cosmetic results. Then we look at the complication risk. Clearly, you can use some quite interesting tools, such as this one from the American College of Surgeons that is able to create a stratification about risk of complication. You can have high risk, intermediate risk, or low risk, and then decide the kind of surgery or breast conserving surgery you want to use. If you have a patient that is at high risk of complication, probably you are going to avoid therapeutic mammoplasties. And then, of course, and this is the most important thing in our pathway, you decide skin incision after a thorough investigation of patient values. Because sometimes you have patients that are not, I mean, in a scale, they are not rating at level 1 cosmetic results. They just want the most simple operation as a day case, a very simple scar, not concerned about cosmetic results. They want to go back at home, because they are elderly, they are taking care of someone else. They are not really, cosmetic result is not the first issue in the therapeutic pathway. So investigate very clearly patient values. And this is something that we try to do as much as possible. We do very long conversations, sometimes even 1 hour of conversation. I'm used to discuss directly with patient all the options that I can offer them. Sometimes I like drawings, which is quite a useful tool in my hands. But then you can use some decision aids that are standardized. And you can see this one that is designed by Professor Glyn Elwin and published as an option grid, which is a very interesting tool that the patient can take with herself at home. They can take it at home, and they can read and answer the most frequently asked questions, which are very simple questions, such as what is removed, which surgery is the best for long-term survival, will I need more than 1 operation of the breast? Very simple questions. The team of Greta have tried to make an adaptation of the option grid, which is this one. Clearly, this is not validated, so I cannot recommend it for standard use in clinical practice. We are showing here not only questions and answers, but also scar placement, which is something that patients most of the times would like to visualize. Because if I'm talking about a therapeutic mammoplasty, probably they're not going to understand anything. But if I show them the scars, probably this is something that will clarify where the scars are going to be put. They will have very long scars sometimes if they got very large breasts, and so on. I want to show this very nice tool. This is a cognitive exercise that was used for a trial back in 2013. It's very useful for mastectomy and breast reconstruction, can help either the surgeon and the patient to understand if the patient is more keen to undergo an autologous breast reconstruction or an implant-based breast reconstruction. I think that we can study something similar also for breast conserving surgery. As you can say, on one side, there is minimal scars on other parts of the body, lowest risk for very serious complication. So I think that we have to study and make an adaptation of this interesting cognitive tool for patients in order to understand how they want to manage their scars in their breast. Please don't forget that the breast is the main tool for gender identity. So I want to show you some simple cases of breast conserving surgery performed in patients operated in my hospital, which is a tertiary care in Sicily, Ospedale Cannizzaro. So you can see this is quite a young lady who had a lump in the upper pole of the right breast. The lump was less than 20 millimeters. She had BRCA negative. It was a luminal cancer. She had moderate ptosis, but the breast was quite large. She had some good donor sites for flaps and for fat as well, a low risk of complication. She was a young lady, and she decided to keep the shape of the breast as much as possible, and she requested this round block technique for removal of the cancer. So you can see that the results are very rewarding. More or less is the same shape between the pre-op and the post-op, and she is very satisfied. Now I want to show you another patient. This is an elderly patient. She was more than 70 years old. She's quite obese. She had a bilateral breast cancer less than 2 centimeters on both sides. I like this picture because these are demonstrating that even if you perform very simple surgery, if you make if you study the case and you make a very accurate preoperative planning, you can sort with quite good results, even in large ectotic breast, without performing complex bilateral surgical techniques such as therapeutic mammoplasties, in which probably this patient was absolutely not interested. And even in this case, she definitely asked for minimal aggressiveness, and these are the results that, in my opinion, are quite good results. And now have a look at this lady. She is quite young. She has a lump in the left breast. Even in this case, it's a small lump, but she's got quite small breast. She has a low risk of complication. Flap donor sites are not in the back or in the abdomen. She's quite flat. She's thin and fit. And again, she requested to avoid the mastectomy as much as possible and to avoid bad scars. And I think she had again this technique with a round block, which is not really the Benelli technique. It's just a perioral access with good results. And in this case, we performed a quantitative assessment of results. It is very important not to show only photographs, but try as much as possible to investigate the results with standard tools, and in order to share your values with other colleagues, in order to exactly quantify the results of your surgery. And you can see that she had more or less the same results in the breast Q in 4 domains: satisfaction with breast, psychosocial satisfaction, physical and sexual well-being. The results are more or less the same in the pre and the post-op. And even performing the BCCT.core valuation, which is a standard in my region for assessment of cosmetic results, the evaluation performed before and after the operation was good and good. And I want to advise you to use this tool either before and after the operation to see the changes. As you can see in the following case, this is a young lady, again, where the tumor in the lower pole of the breast, less than 2 centimeters, but she had a sagging breast, was rather ptotic. She was unhappy with the shape of the breast, and she asked for a bilateral therapeutic mammoplasty for maximum reshape. And so you can see the results either in the pictures here in the photograph, which are very good results, more or less like cosmetic surgery. And which is most importantly, she had a jump in satisfaction with breast that preoperatively was 48 and postoperatively was 85. I heard her this morning on the phone and she said, "Doctor, I have just some pain in the inframammary fold when I'm wearing a bra, but really I don't need to use a bra. So I'm very happy with the results of your bilateral surgery." So have a look at the cosmetic results using the bcct.core. Again, I want to suggest you to use it in the pre-op and then in the post-op. She had a good rating even in the pre-op, but then on the post-op, the results are excellent. So we can go now to the conclusion. I want to advise you that the final decision on scar placement is based on a complex mix of multiple features. And please be aware and investigate patients' values before planning skin incision, because cosmetic results are not the only goal of breast conserving surgery. And again, try to audit your results and think about possible improvements and share your results with other patients. I just want to thank all the contributors and the team of Greta, Nicola, who is one of the participants, Maurizio, who is in Milan, and Francesca, who assisted me in getting the data and preparing the presentation. Thank you for your attention.
Great talk, Giuseppe, as usual. I still remember your talk in the escalation of breast surgery in ABS a couple of years ago. One of the talks I'll always remember, and this is another great talk. Many thanks for that. Also,
thank you.
Beta with Giuseppe, with Prof. Nava, with Nicola. There's the MBN 2020, which is online webinar series. It's great. They have great speakers in those. Also, check on the Greta website and you'll find the details.